All right, guys, we're going to move on to vaginal and vulvar abnormalities. All right, I'm just going to say a couple of words on labial fusion because there's really not much tested, okay? So labial fusion is exactly what it sounds like. The labia are fused, okay? It's caused by excess androgens, all right? The most common cause is going to be, yep, that's right, 21 beta hydroxylase, okay, deficiency. 21 beta hydroxylase deficiency, which we will talk about in pediatrics, basically causes labial fusion. And what is going to be your treatment? The only treatment option is reconstructive surgery. All right, that's pretty much all you need to know for labial fusion, okay? Like I said, not much on it. There are 3 different epithelial abnormalities, okay? Now, some people get them confused, so we're going to start with the confusing ones first, and then we're going to move on to the last one. 1, lichen sclerosis. All right, now lichen sclerosis is whitening, okay? So it's whitening of the thin skin, and whitening and thinning of the skin between the labia and the perineum, okay? So white, thin, between labia and perineum, all right? In postmenopausal women, this is a precursor to cancer, okay? Postmenopausal precursor to CA, all right? You have an increased risk of cancer. Now, what's your treatment going to be? Your treatment is going to be topical steroids. Okay? Now, this one, they get confused with lichen planus. I guess because the first word is the same. However, lichen planus happens between the 30s and the 60s, and it's a purplish lesion, purplish, flat, and it's in the vulva, okay? Purple, flat, and it's in the labia, okay? Now, the treatment is the same, topical steroids. All right? Now, the last one is squamous cell hyperplasia. Now, what happens with hyperplasia? Now, these patients have chronic itchiness of the vulva and the vagina. Okay, vagina, sorry. So they have chronic itchiness, okay? And when they itch and they itch and they itch and it gets irritated, it gets thick, and that's basically what happens, okay? So you get hyperkeratosis. Remember that? Hyperkeratosis. All right, it's basically thickening, whitening of the skin, and it's due to the chronic itchiness, chronic pruritus, all right? And your treatment is going to be anything that's going to stop the itch. Just stop the itch, all right? Sitz baths is common, okay? But you want to stop the itchiness. All right, now we are going to move on to something called a Bartholin gland cyst. Now, Bartholin gland cysts. Your Bartholin gland cyst is something that you will never forget, all right? You're working in the ER and the patient, usually a younger patient, comes in and says, Dr. August, I'm having pain in my vagina. I swear to you, I don't know what's going on, but there's a big mass there. It's giving me trouble walking, and it hurts. It hurts a lot. Okay, so you do a physical exam. Okay, as she spreads her legs, you see a huge fluctuant mass in the vagina. It's usually deep, okay? That's a Bartholin gland cyst or abscess. Now, The Bartholin glands, these are normal things, okay? They don't always have to have a cyst or an abscess. However, that's generally the only time you see them. All right? So they are on the lateral sides of the vagina. All right? And they normally secrete mucus. All right? So this is normal. However, all right, if they get blocked or clogged or anything, that's when a cyst or an abscess develops. So if you have any sort of obstruction, that equals a cyst or abscess. All right, and like I said before, your symptoms of the cyst or the abscess are going to be pain, all right, erythema, mass, all right, and dyspareunia, pain while having sex. And if it's large enough, they're even going to have pain while walking. All right, what are you going to do about it? Well, on physical exam, like I had said, you are going to see the mass, okay? You're going to see the mass, you're going to feel that it's fluctuant. And what do you do with all abscesses? Abscesses, regardless of where they are, you need to IND it. All right? So, I know, yummy, right? So basically what you are going to do is you are going to numb the area, you're going to IND it, you're going to cut an incision in it, and all of the pus is going to be expelled. You want to make sure that you culture that pus because you want to make sure that you do not have gonorrhea or chlamydia that had caused it. So your treatment is going to be to IND it, and you're going to culture the pus. Now, this can happen multiple times. If it happens in the same place over and over and over again, you're going to do what's called a marsupilization. Dr. August, what's a marsupilization? Well, basically what that is, it's like an IND, okay? However, you are going to actually suture the IND open so it continues to have drainage, okay? So you're going to keep it open with sutures. All right. You don't really need to give antibiotics for this, just like an IND. Antibiotics usually, just like with most abscesses, antibiotics usually don't work. The treatment is to IND it and to get rid of the infection. Now, moving on, we are going to move on to vaginitis. All right? Vaginitis. Now, what are your risk factors for vaginitis? Well, your risk factors are anything that changes the pH balance of the vagina. Right? Anything that changes the pH balance of the vagina, like antibiotics. Antibiotics very commonly cause this. Diabetes. Diabetes commonly causes this. There's lots and lots and lots of things. These are the most common two that cause it. Now, there's three different causes. 1, bacterial vaginosis. 2, candida. 3, trichomonas. All right. Now, what causes these things? Well, for BV, that's going to be Gardnerella. Now, Gardnerella is a normal flora in the vagina. However, when it overgrows, it causes BV. All right. Now, BV has a fishy odor to it. All right. It's a copious amount of vaginal discharge with a fishy odor. Now, when you do a physical exam and you smell that fishy odor, that's not diagnostic enough. You actually should look at it under the microscope, and under the microscope, you're going to see something called clue cells. Now, clue cells is going to be your tip-off, all right? This is a very common board question. Clue cells is found in bacterial vaginosis, which is an overgrowth of your Gardnerella. All right, how do you treat it? Well, you treat it with metronidazole. Dr. August, you need to treat the partner? No, it's an overgrowth of the normal bacteria. Just treat the patient, okay? You just treat the patient and you give them metronidazole, or you can give them clindamycin. Most commonly metronidazole. Now, Candida. Candida is caused by Candida albicans, okay? Now, this is extremely common. This is a yeast infection, okay? Yeast infections are caused by Candida albicans. They cause a white, thick, cheese-like vaginal discharge. It also causes extreme itchiness or pruritus, okay? This is common after antibiotics, and if you keep getting recurrent vaginitis with Candida, you're at increased risk for diabetes. So if you keep getting yeast infection after yeast infection after yeast infection, your doctor should test you for diabetes. Why? Because you're so sweet, oh so sweet. And so Candida likes to live there, okay? So if you have uncontrolled diabetes or you have diabetes and you don't know it yet, you will continue to get recurrent Candida infections. Now, on your KOH prep under the slide, what are you going to see? You're going to see pseudohyphae. And how are you going to treat this? Fluconazole, ketoconazole, clotrimazole, any of the azoles, okay? And nystatin. All right? Trichomonas. Now, trichomonas is caused by, correct, Trichomonas vaginalis. Trichomonas vaginalis now, this is an STD, okay? Causes vaginitis, but it's spread from partner to partner, all right? What does it give you? It gives you green, frothy, copious amounts of vaginal discharge, right? Green and frothy. And on your slide, your saline wet mount, you are going to see motile organisms. You're going to see little things that are moving everywhere, okay? That's going to be trichomonas, okay? Now, you're going to know that it's not sperm, okay? Because sperm, you can clearly tell what a sperm is versus trichomonas. Trichomonas is more of a large oval-like with a small little flagella there, okay? While sperm has a small head and a long tail, all right? So you're going to be able to tell the difference. What are you going to treat these patients with? That's right, metronidazole. However, Dr. August, do you have to treat the patient? Yes. Do you have to treat the partner? Of course. Since this is an STD, you are going to treat both the patient and the partner for trichomonas, okay, with metronidazole. Alrighty, now we are going to move on to malignant epithelial or malignant types of cancer in the vulva. First, Paget's. Okay? Now, Paget's disease is an intraepithelial. Okay? So what? Intraepithelial lesion, which means inside the epithelium. Okay? It's an intraepithelial lesion, and it occurs usually in most postmenopausal women. All right? And it has a soreness of the vagina. You sometimes have itchiness, and it's a red lesion with white on top of it. Okay? So symptom-wise, you're going to have soreness and itchiness of the vulva, and it is going to be a red lesion with white on top. All right. What's your diagnostic test going to be? As with anything in the skin, usually it's going to be biopsy. It's no different in the vagina. Biopsy is going to tell you for sure what it is. What's your treatment? Your treatment is going to be a vulvectomy. Okay. If it's bilateral, you're going to do a complete vulvectomy. Otherwise, if it's on one side, you can do a modified. All right. You don't need to know what that entails during your Part 2 exam. All right. That's more of an OBGYN board question. All right. Let's move on to squamous cell carcinoma. All right. Squamous cell carcinoma. Now, this is the most common type. What did I say? It's the most common type of cancer in the vulva, okay? It is basically itchy, bloody vaginal discharge. So you have an itchy and your vaginal bloody discharge. Now, on physical exam, this has a wide range of what it looks like, okay? So you can look at it, and it can be like a small ulcerative lesion, which could be just a tip-off that something's going on. So you're going to look at it, you might see an ulcerative lesion. However, in the patients that it's really bad, you might see a cauliflower-like lesion, all right? So it's hard to test you on what it looks like because there's such a range. So most likely they're not going to tell you what it looks like. They're going to tell you the diagnostic test. The diagnostic test is going to be a biopsy. What it shows on biopsy is most likely what you're going to be asked about. You could be asked about some weird lesion on the vulva or the vagina, and what are you going to say? You're going to say biopsy, okay? Because any weird lesion, you're going to biopsy it. So your diagnostic test is going to be a biopsy. And biopsy is then going to help you stage it, okay? Once you have the biopsy results, you're going to be able to stage it. Now, staging is a little bit complicated because, one, is carcinoma in situ, okay? So it's just inside the epithelium. Two, it's the vaginal wall, meaning less than 2 centimeters. 3 is going to be your vulva. It's going to go into the vulva and the perineum. And that's more than 2 centimeters. 4 is going to be that the tumor has extended, okay? And there's unilateral, so one-sided lymph node. All right, 5 is going to be bilateral lymph nodes, okay, and that's even further. And then lastly, you're going to have distant metastasis, would be stage 6. All right, now what's your treatment for these? Obviously, your treatment for any type of cancer is going to be to remove it. So you are going to do a vulvectomy. And you're probably going to have to resect the lymph nodes if the lymph nodes are involved, so you'll have to do a lymphadenectomy. All right, basically, like I said, it's hard to test squamous cell carcinoma, so generally what they will ask is, they want you to know that it's the most common type, that there is some weird lesion, you need to do a biopsy for it. All right, so a quick overview. Labial fusion is exactly what it means. Your labia is fused together. The only treatment is reconstructive surgery. And your most common reason is the 21-beta hydroxylase. Your epithelial changes lichen sclerosis, lichen planus, and squamous cell hyperplasia. For the lichen sclerosis, that's white and thin. Topical steroids is your answer. Lichen planus is purple and flat. Okay, topical steroids is your answer. For squamous cell hyperplasia, that's most commonly with people that have chronic itchiness. You want to stop the itchiness with sitz baths, and that's a thick white hyperkeratosis, all right? For your Bartholin gland cysts, Bartholin glands are normal. They're in the lateral sides of the vagina. They secrete mucus. When they become obstructed, it causes a cyst or an abscess. As with all cysts and abscesses, you are going to IND it. IND, make sure you send the pus for culture. You want to make sure that there's no infection. If this is recurrent and happens in the same place over and over, you're going to do what's called marsupialization. Vaginitis. Vaginitis, your risk factor is going to be anything that changes the pH of the vagina. Your three main types, BV. BV is caused by Gardnerella, which is a normal flora, overgrowth of normal flora. Causes a fishy odor. You're going to see clue cells on your slide, and you're treated with metronidazole or clindamycin, patient only. Candida albicans is your bacteria. Sorry, it's got a white, thick, cheesy discharge. All right. On KOH, you're going to see pseudo-hyphae, and you're going to treat with the azoles, fluconazole, clotrimazole, any of the azoles, and nystatin. For trichomonas is an STD. It's caused by Trichomonas vaginalis. You're going to see motile organisms on your saline wet mount, and it causes a green, frothy vaginal discharge. Metronidazole for patient and partner. Lastly, Paget's. Paget's disease is an intraepithelial lesion. Your symptoms is soreness and itchiness. It's a red lesion with white on top. You're going to do a biopsy. Treatment is vulvectomy. Squamous cell carcinoma, most common reason is it's the most common type of cancer in the vulvar area. You have itchy, bloody vaginal discharge, and your physical exam is going to show anything from an ulcerative lesion, small ulcerative lesion, to a large cauliflower lesion. They want you to know that any weird lesion you're going to biopsy. Once you biopsy, it'll tell you what you need to do to stage it. Staging we reviewed already, and your treatment is going to be a vulvectomy. All right, guys, that's it for the vulva and vagina. See you in the next chapter.